Welcome. Everyone, thank you for joining us. Minnesota Endo Warriors Board members are super excited to bring you these Meet the Doctor events. A little bit about myself. I am Alamanda Calvert. I've been on the board since last year, but have been, in the endo community for 5 years volunteering with the board. My endometriosis started 5 years ago. Well, the knowledge of it started when an OB finally brought up that perhaps that is why I could not get pregnant. So this call tonight is going to be very interesting for me as well. We have compiled a list of the questions that you guys have submitted, and we hope to get through as many of those as possible today. With us today, we have Zarak Khan. He is a double board certified in OBGYN and reproductive endocrinology and infertility, as well as minimally invasive gynecological surgery and reproductive organ transplant, and has additional training in endometriosis excision surgery. Dr. Khan joined the Mayo Clinic in 2007, where he completed a residency in obstetrics and gynecology, and then a funded master's in clinical research and his first fellowship in reproductive endocrinology and infertility. Dr. Khan was awarded the prestigious Mayo Clinic Scholar, which allowed him to complete a second traveling fellowship. Through this program, he worked in Germany, as well as Switzerland, and at the Center of Endometriosis Care in Atlanta, under the mentorship of Dr. Ken Snervo. He completed his training in ovarian transplantation and uterus transplantation in Denmark, Sweden, and Ohio. He currently works full-time as a reproductive surgeon at Mayo Clinic in Rochester, where he sees patients with advanced endometriosis, as well as several other things. His passion lies in helping women with advanced endometriosis who are eagerly seeking fertility. Welcome.
Thank you.
So just for kind of our intro questions, we are wondering what led you to learn about endometriosis and why do you continue?
Thank you. And first of all, thank you to Alamanda and Kate and the whole Minnesota Endo Warriors organization, who always does amazing work. And it's a privilege and an honor to be here to speak to you guys about my passion area, which is endometriosis and endometriosis-associated infertility. Getting right into sort of why I chose this line of area for a career choice that actually stems back to my early childhood. I ironically am an oops baby from 2 OBGYNs, and I have 3 older sisters that are almost a generation older than I am. So I grew up around talk of anatomy and physiology, and with all 3 of my sisters and my parents being an OBGYN, always talks around women's healthcare in a part of the world in Pakistan where women's healthcare does not have a lot of emphasis. And so really it was I always knew from a very beginning that women's healthcare would be a passion area for me for my career as well. But really, when I look back to my early childhood of what sort of inspired me to do endometriosis, it really sort of stems back to a few different things. One would be my parents and my siblings always talking about how difficult endometriosis was, how hard those surgeries were, and when they left, they just felt dissatisfied. They felt that they couldn't help the patient too much. That sort of translated into my training. I'll be honest with you, in the mid-2000s, 2007 to 2013, 14, I did my training at Mayo Clinic, which is probably one of the most prestigious training places in North America for OBGYN. And we would still continuously encounter patients with advanced endometriosis where we really didn't have good options for these patients. We would do sort of those peek and treat things. We would do a laparoscopy, get a little biopsy, put people on Lupron, tell them that they couldn't get pregnant, or they would do Lupron and IVF, or it was just very non-gratifying even during my training. And that further strengthened my passion for this area and trying to learn more. trying to seek these opportunities worldwide. As you had mentioned, I did specifically design my Mayo Clinic Scholar to travel far and wide in Europe to learn from the experts that did cutting-edge endometriosis excision surgery in Switzerland and in Denmark and in the Netherlands and in Ohio and Georgia. And that sort of further strengthened my passion for this area. I wanted to be that person that not only entered the OR with complete confidence, knowing that if there was advanced disease, I would be able to tackle it, excise it, and treat it and remove it, but also wanted to be that bridge for women and patients that are seeking fertility. As we know, in the real world, like, outside of my practice and 2 or 3 other people worldwide, you have your fertility person is separate and your endometriosis person is separate, and they may or may not talk to each other. They may not be in line with each other. And really, I wanted to serve that bridge and be that bridge across that gap of the world of fertility as well as endometriosis and pain, because they're all intertwined with one another, as several of you can attest to. And so really, that was primarily the reason why I chose this line of work to be my area in my career.
Awesome. That is quite the history. So the next question is, what has surprised you the most about this disease?
That's a really good question. I think that what surprises me most about the disease is how much we still don't know about it, and how much there is still a complete lack of good cutting edge research and lack of funding, and a lack of attention to this disease on a national level. I'm so impressed with grassroots movements, patient advocacy groups, and groups like yours that are actually leading that discussion. And the onus should be on us that are in this field, and we're still continuing to try our best, but it takes a whole village to continue this grassroots movement. So I think the most surprising thing to me still, ironically, is the lack of awareness and the lack of passion from people outside of our world, outside of the endo warriors, outside of the people that are struggling with this, outside of the people that are catering to this on a daily basis. What also surprises me every single day, and I know this might sound corny, is the grit and the integrity and the passion patients have for their disease and the advocacy that they continue to show me every single day. And I always say I'm not super old, so hopefully I'm mid-career right now. But earlier in my career, I never saw that, and I'm continuing to see that more and more. Not only that, but the passion and the level of enthusiasm and really everything else that the patient brings to the office. So I'm very honest in saying I learn a lot from my patients, and I get inspired by patients as well quite a bit. So I think that's surprising, but in a good way surprising. And then the final thing, of course, is something that I completely nerd out on, is every single surgery is a jigsaw puzzle for me, and it's surprising in itself. Every single surgery is so unique in itself because every person is so different. And as we sort of further go into these conversations, it is so hard because you cannot put endometriosis in a bucket. You cannot, it's hard. And I caution patients to that, but patients like to compare notes. And, well, my girlfriend had this, and I'm going to do this, and I'm going to get pregnant. Or my sister had this, and I'm going to do this, and I will get pregnant or be pain-free. Every person is so unique and so different, and it is an individualized disease with individualized treatment modalities, in my opinion. And that continues to make this disease an enigma, but also so interesting, fascinating, surprising at the same time. It's like a mix of emotions. All like my party line is, I love endo, but I hate endo, right? Like I absolutely love endo, but I absolutely hate endo at the same time for different reasons. And I think that's what continues to keep me so inspired and engaged in this very, very ever evolving field of disease.
Yeah, that's awesome. It makes sense. So given that you are at Mayo and work with more kind of advanced endometriosis cases, what is kind of the process to get into endo, or to get in to see you for endo, the timeline, as well as for fertility treatments?
Absolutely. That's a great question, and one that I don't have ideal answers to, I'll be honest with you from the get-go. Okay, as you guys know, there are very few excision-trained specialists in the state of Minnesota, and hopefully there'll be some more news of expansion even within Mayo, within REI, and within minimally invasive GYN surgery for more excision specialists, because we see the need for that. But right now, the process is, we have a number, and I'm happy to put it in the chat, and I'll put it in the chat, but it's 507-284-9792 is a number, which is the appointment desk for GYN endometriosis. The first step is for the patient to call that number and get in touch with a scheduler and give them their information. If they have a Mayo Clinic number, it makes it easier. We can set up everything. If they don't, we get them a Mayo Clinic number right away. And then the next set of points are, we have a list of questionnaires, so primarily 2 questionnaires. One is for the International Pelvic Pain Society Modified Questionnaire, and the other one is an intake questionnaire. Of course, we would like any records that patients have from before, and imaging from outside would be ideal. And then we, as a group, we have a core endometriosis group that's a multidisciplinary team, review every single patient, every single piece of record, and then decide what kind of free sort of appointment opportunities we still have. So what blood tests still need to be done, especially for people seeking fertility. We like to have an awareness of ovarian reserve. We like to have an awareness of semen analysis if the patient has a male partner, those sort of things. And then the most critical and most important thing that we emphasize on a lot is imaging. You guys are aware of this too, but we are leaning more and more towards imaging being primarily a diagnostic or a screening tool for endometriosis rather than surgery, and then going on to surgery as a second step, or laparoscopy as a second step for diagnosis, because we don't have good blood tests or any other screening tests available right now. The imaging part, I really want to put in my 2 cents here. I think imaging is great, even if it's from the outside facility. Imaging, what I talk about, advanced imaging, is either MRI or specialized advanced ultrasound for endometriosis that is not an ordinary ultrasound. It's a 90-minute ultrasound. It requires a bowel prep, and it's specifically really important for deep disease or deep lesions in the colorectal or the rectosigmoid area or the rectum. That, or an MRI, a specialized MRI protocol that we brought in from Switzerland and Germany. They've been at least a decade ahead of us with that, where we give certain substances called glucagon that slows down bowel motility. We use vaginal gel. We use a 3 Tesla magnet for our MRI, and we use cuts that are much thinner to really identify the disease much better. And in our experience, MRI actually overcalls and not undercalls disease. And as a surgeon, I want to be prepared for the worst case scenario, not the best case scenario. Because as you know, even in surgery, it's a team sport. So I do what I do, and I do it really well, but I don't do ureteric reimplantations. I don't do bowel resections, and I use my multidisciplinary team to do that. And so those are some modalities that we recommend getting done here at Mayo if the patient really wants treatment here. Because oftentimes we'll say patient wants to do MRI locally and wants to show up for an appointment. I just don't think that that patient gets the best service that we can provide them for endometriosis care. I'm sorry, I think you're on mute, but to add to your question, the wait time, I'll be honest with you, with the wait time right now, and I feel horrible about this because I have patients coming to clinic, and when I see them, they said, well, I've waited 6 months to see you. And I tell you that's flattering for the first 2 or 3 times, and then it gets really, you carry a sense of guilt around it because you really want to help patients. The last thing I want people to be is in pain. And it's probably somewhere between a 2 to 3 month wait time. So right now I'm looking at seeing patients in the clinic in June, with surgeries probably in May at this point, but May, June around the same time. So 2 or 3 month time frame. I'm hoping that lag time is going to continue to decrease as we continue to hire more trained excision surgeons for endometriosis that can tackle advanced disease.
Okay, thank you. Yeah, that's very interesting about the imaging, because we know we hear a lot about the issues with imaging, but it's very interesting to hear that there are more advanced ways to do it.
Absolutely. And we're continuing to do research on that too. I'm sure we'll get to that when we talk about more research.
Very good. And then, so now we're going to kind of jump into the fertility side, but obviously how endo is impacting fertility. So first, could you give us kind of a brief overview of how endo can affect fertility? Obviously, there's many different ways.
Absolutely. The one-line answer is we still don't know, and that's why it's called unexplained infertility, which is exceedingly annoying to hear, but is the truth. Now, there are several hypotheses, which means there's several theories that have generated for why endometriosis impacts fertility. And with advanced disease specifically, there's a big impact of endometriosis on fertility. There's about 7 proposed hypotheses on how endometriosis can impact fertility. The biggest one, of course, is mechanical or physical obstruction of fallopian tubes due to scar tissue or a frozen pelvis. Of course, with blocked fallopian tubes, the mechanics of reproduction does not work. The egg is not picked up by the tube, fertilization does not occur. So that is probably one of the most accepted theories, because we see scar tissue, we see blocked fallopian tubes in people with endometriosis quite a bit compared to people without endometriosis. There's also direct impact of, the word I'll use is cytokines. Cytokines are messages that inflammatory cells produce in the body. And so cytokines are essentially messages from the inflammatory cells that are much higher in women with endometriosis compared to women that do not have endometriosis. And those cytokines in themselves are directly toxic to sperm. They can paralyze sperm. They can inhibit ovulation from the ovary. They can actually paralyze embryo transport. So by the time the embryo gets to the uterus, implantation window has already passed. And of course, they can affect the peristalsis, or the movement of the fallopian tubes, which impacts egg pickup. Other reasons for impacts on fertility can be a decreased implantation. So we now know that women with endometriosis, even if we take an egg from them and create an embryo and use a surrogate or a gestational carrier, use somebody else's uterus to transplant that embryo or transport or implant that embryo, those implantation rates are much lower than if we were to take an embryo from somebody without endometriosis and use a surrogate. And vice versa, even if we used a person that has endometriosis as a gestational carrier, those implantation rates are much lower than somebody without endometriosis. Their implantation rates are higher, even if we're using something like donor egg. And so we now know that there is an impact on implantation of the embryo on the uterus as well. And the million-dollar question there is it endometriosis? Is it adenomyosis, which oftentimes gets sort of jumbled into one, especially for people that don't do this on a daily basis. And endo and adeno are 2 completely different. They're related, they're evil twin sisters, but they have completely different implications, especially on symptomatology, fertility impact, and also treatment modalities. So it's really important to understand that we are now hopefully at that level in our education with patients and with providers, that we ought to start talking about endo and adeno as 2 separate entities, because they're completely separate entities. They're related, but they're separate entities. And also the final one with endometriosis and fertility is people with endometriosis can also have egg development all the way, but egg release from the ovary is an issue. The medical term for that is luteinized unruptured follicle, but the follicles or the egg doesn't release from the ovary, sort of a thing. And that's fairly common in patients with endometriosis as well. So several different mechanisms of how endometriosis can impact fertility. And of course, the biggest one is low ovarian reserve, because endometriomas or lesions in the ovary can chew into a finite ovarian reserve that every woman is born with.
Yeah, that is definitely a few different ways. So kind of a follow-up to that, obviously endometriosis surgery, excision, how can that affect fertility? And really, does it improve fertility? I will say in my case, yes. I had excision with Dr. Palmer, and the first time we tried post-excision, we ended up pregnant with my first daughter. So
Amazing.
that was a miracle, obviously, to us. But I know people who they still need IVF. They still need, other fertility treatments.
Absolutely. And what a wonderful story to share, right? We love success stories like that. And so I'll be rather direct and honest here. We have some data that we don't have excellent data, but we do have level A data, which is the best kind of data we can have in medicine, which is randomized controlled trials where we completely blind patients, providers, and do the best sort of experiment or clinical data that we can provide. Now, here is how I sort of think about fertility and endometriosis in my mind. In my mind, there are two different sort of flavors of endometriosis and fertility when we think about treatment modalities and surgery. One is when we have advanced disease. So what do I mean by advanced disease? What I mean by advanced disease is if we have bulky disease that can be seen on imaging, and ideally good imaging, not just an ultrasound with somebody that is doing a pelvic ultrasound and knows nothing about endometriosis, not just an MRI in a 1.5 or 1.0 Tesla magnet from the 1970s. We're talking about advanced ideal imaging. And if that shows bulky disease, meaning an endometrioma, a lesion in the rectum, a lesion in the bladder, any nodules, any actual disease that we're seeing, macroscopic disease, the data is fairly clear that in that scenario, we still are unsure of what impact it has on fertility, but anecdotally, and data from our cohort included, we're in the process of publishing that, it really shows that advanced disease ought to be excised prior to trying on your own or fertility treatments. Especially if the patient has pain, because there's clear data to show that excision of disease will help with pain. So to me, in my mind, it kills two birds with one stone. Not only does it improve your pain, but also enhances fertility for you to either try on your own, especially if the fallopian tubes are open for a little bit, or go into fertility treatments. For minimal stage disease, where you have endometriosis, or we don't know if you have endometriosis, but your symptoms are clearly spelling out endometriosis, and we do advanced imaging and we don't see anything at all, maybe a little tethering, maybe a little scar tissue, a little band of scar tissue here and there. For pain, yes, surgery ought to be had and exploration ought to be done for laparoscopy. But for fertility, there's clear data to show that surgery in that scenario is actually ineffective. So you can do surgery for minimal stage disease, and I think that can help the patient's pain 100%. But you ought to be doing, so the data would show you need to do 42 surgeries to get one patient pregnant spontaneously. And those are the odds, and I lay them out for patients, right? I think and this is why I like at least the way I approach this disease, because it's not me telling you what to do, it's us discussing it together and formulating a plan for what is best for you. If 1 in 42 odds are good odds for you, sure, we'll go to surgery. But I'm telling you that would be ineffective for enhancement of fertility, but it will be effective most likely for your pain if your pain is generated from endometriosis for sure. So in those scenarios where there's minimal disease and the primary desire is that of fertility, then there's no doubt that moving forward with some form of fertility treatment, either Clomid IUI or ideally in vitro fertilization, is the next best step and route for patients.
So the 1 in 42, is that applicable to just people without pain or everyone with endo?
Great question. That is applicable for people with pain and endometriosis. Okay. So and for infertility, sorry, with pain and infertility. Okay. In these two studies, all patients had proven endometriosis. Okay. So this isn't also patients with, because remember, 80% of pelvic pain is endometriosis, but let's not forget about the 20% of patients that are still having pain, but don't have endometriosis. And that is a group of patients I do not want to ignore, because that's a group of patients that constantly get ignored because we don't have good enough management strategies for them. right? So I always tell patients, just because I don't have a magic cure for your symptoms does not give me the right to invalidate your symptoms. I really truly believe that sane patients, which most patients are absolutely sane, well, nobody pretends to be in pain. And so the first thing we actually do is to validate symptoms for patients, because it is really important that we stop telling women that this is all in their head. I feel very passionate about that. And I'm sorry if I'm digressing, but I think it's really important to validate patients' concerns. Nobody, like, I can't imagine a single person who just wants to pretend to be in pain. Like, that's not what it is. But it's also important to understand that maybe 1 out of 5 times it's not endometriosis. And that's where we really need to sort of hone in and focus down. But it really has to be a diagnosis of exclusion. You really can't say that. You really have to rule that out by an extensive laparoscopy. You have to seek disease first. If there's no disease, when you look for it and you don't find disease, that's only then can you say this patient doesn't have endometriosis.
Yeah, that is, I think, a very different way than a lot of people think about it. They want to exclude everything else until, at least the first doctor I saw was like, well, it could be this or this or this. And I was like, what about endo?
And I'll be rather honest, and this is why I'm very honest in confessing this, right? Because I'll tell you why, and I don't mean to project my beliefs on other people, but at least I tell you that's how I felt when I was in training. Because we were scared of doing these surgeries because they're tough, difficult surgeries. We tended to put band-aids on things and said, oh, it could be endo, but you need advanced fertility treatment anyway. Or, oh, it could be endo, but why don't you do Lupron and let's just see if you feel better. And let's, and that is exactly the reason why I wanted to do 5 extra years of training to be able to answer those questions, because I could not buy that ever.
Yeah, yes, that makes sense. I mean, it takes a lot of additional training and expertise to deal with those complex endo cases. All right, so we had a couple people write in about whether or not another surgery or even an initial surgery would be recommended if they've had several failed cycles or several miscarriages.
Yeah, great question. And I think that's a fairly loaded question because it just depends on circumstances of what the patient brings in, right? If a patient has pain and they've had laparoscopy with a person that I know or trust that knows how to do excision surgery, knows how to identify, because also remember, it's not just excision surgery. It's a trained eye because the disease has many, many faces, right? So you could have had a laparoscopy with somebody, and I'm not trying to be critical of my colleagues that don't do endometriosis every day. They do things that I don't do at all and have no idea about how to do. But if you don't live in this world, if you don't eat it, breathe it, live it every single day, I think that you are probably not as qualified to look for disease. I actually do a lecture with my trainees, and we call it Where's Waldo, right? I have several different pictures, intraoperative pictures that I tell and I quiz my trainees and saying what's endo, what's not, and even actually physicians on what's endo and what's not. And nobody ever gets even close to a perfect score, even close to a 50% score on that, because the disease has so many different faces. It's a chameleon, right? And so if somebody has had endometriosis surgery in the past from an excision specialist that I trust, that I know what they're doing, and they're continuing to have failures from IVF cycles or not success in implantation, we obviously, the first thing we want to know is, do they have adenomyosis or not? Because I'll be honest with you, even in the endo world, people are just learning about adenomyosis. I have a lot of passion about that because adenomyosis is big in the fertility world, not as big as in the endo world, but it's now becoming a thing. So the first thing for fertility and lack of implantation is ruling out adenomyosis, really seeing if the patient has had good treatments, meaning like if they've had adequate suppression prior to embryo transfers, if they've done genetic testing on the embryo, if there's no other causes of infertility. So I don't have a blanket statement answer to that because it really depends on what the patient is bringing into the equation with them. I'll tell you the ultimate sort of we're in outer space. Answer is yes, sometimes we have to use third party, meaning we may use a surrogate or a gestational carrier if we've tried several different tries on a uterus that has adenomyosis, or if a person has advanced endometriosis, we can almost always excise it with surgery. But I don't know if, like I said, with advanced disease, there's still lack of controlled data to show whether that truly helps or not. So it's not a blanket answer to that question, but it's really making sure we're going down the list of things, checking each thing meticulously, and making sure that we're leaving no stone unturned before we tell this patient that we might be looking at third-party options, meaning a gestation carrier, or maybe looking at other alternative means of family building like adoption and things like that. That's further down the list. We have to exhaust that laundry list of things first before we move on to the next.
Yeah, yes, that is. I'm sure it's very individual. And if there is anyone attending who has an individual question about that they'd like answered, please type that into the chat. I know we did get some specific ones, but I want to make sure we cover anyone who is present.
Exactly, because it's absolutely important to understand that, fertility, there's 20 different things that can impact fertility. Endometriosis happens to be a very, very important one. But, oftentimes I'll see people later on in life towards their middle fourth decade. And at that point, your primary driver of fertility is physiology and ovarian age, not necessarily endometriosis, right? So it's just a very, very complex question with 20,000 different offshoots and answers to that. And that's what really makes this area so unique, so interesting, and so engaging, because oftentimes we have to talk to patients about all these things, and it has to be a two-way dialogue. It just has to be.
Yes. All right. So we did receive a question a little bit more specific. Do you see it there?
Yep. So we are talking here about, I'll repeat the question for it being recorded. Do you feel that Lupron depot before embryo transfer is good enough to overcome recurrent pregnancy loss and implantation failure? Or is it laparoscopic surgery recommended with silent endometriosis diagnosis from Receptiva? And hopefully we'll get a little chance to talk about Receptiva testing and quote unquote silent endometriosis. But really, the answer to this is, Depo-Lupron, first of all, is not a treatment for recurrent pregnancy loss or recurrent implantation failure. Depo-Lupron is a good treatment for people with known adenomyosis or extensive endometriosis even after excision surgery. So yes, Depo-Lupron has a role in women that have had endometriosis, extensive endometriosis, even after excision if they're trying to do embryo transfers, and definitely for women that have adenomyosis, it's sort of the best modality that we have to date prior to an embryo transfer. And I say this with caution because I always tell people I have no filter, so please take it with a grain of salt, but I do not believe in Receptiva testing. If you really look at the literature of Receptiva testing, it is lukewarm at best. And I think that again, I don't want to be critical of the Receptiva testing. I think if people that do it, it's okay. I think it's just additional information. But unless, as I mentioned, unless you have bulky endometriosis on imaging, meaning an endometrioma or deep disease in the rectosigmoid or anything like that, silent endometriosis without any symptoms, really, in the world of fertility, there is no role for surgery. And sometimes that's hard to hear for patients because patients almost want surgery to see if that would improve symptoms. But unfortunately, that does not. Now, can we still do a laparoscopy and look? That's an individualized conversation. We certainly can, but it's still important for patients to know before going to surgery that this surgery, in my opinion, is not fertility enhancing. Now, also keep in mind that we tend to dote on anecdotes, right? Like, and not to pick on you, Amanda, right now, but like you said, I had surgery and I got pregnant, right? Now, what is to say that you probably could have gotten pregnant even without surgery, but because you had surgery and you got pregnant, that sticks, right? And that's human nature. It sticks with all of us. And we know that fertility follows the rules of probability and mathematics. So when you take the emotion out of it and purely put numbers and logic into fertility, the more number of embryo transfers you're going to do, the more you're going to deviate to the mean, which means the success. That's what the recurrent pregnancy loss literature shows, that even after a fifth loss, the chances of a sixth success is more than 80%, which is very frustrating to hear as a patient, and I empathize with that. But I can tell you that data and numbers don't lie, but also know that data and numbers generalize people. So we also have to have individual conversations with people, but data and numbers guide our practice and guide how we do things. And so in my opinion, if it's silent, quote unquote, silent endometriosis, meaning there's no bulky disease, really the treatment ought to be looking at going to embryo transfers, and if there's recurrent implantation failure, looking for other avenues for why that's not happening. Is genetic testing done on the embryos or not? Is there adenomyosis or not? What is the embryo quality? Is the embryo quality poor? We look at the development of embryos and see how much blastulation rate there is, and there's so much more there. And in my opinion, if people don't get pregnant after 3 or 4 euploid or genetically tested embryo transfers, that is a time when we start having conversations about the use of a surrogate or a gestational carrier, if that is, of course, not a no-go zone for people. Sometimes that's a no-go zone, and that's a-okay. Then we continue to work with the patient's uterus. But it's also really important to have these difficult, honest conversations with patients, because I know fertility patients will go to the moon and back. Like if I gave you a bike and I said, do something to this and get it to the moon, I promise you will put thought into, oh, maybe if I put wings and a rocket engine on this bike, it could get to the moon. People will put thought into illogical things because I know they want it so bad. And that's where our role comes in, to make sure we're not exploiting our patients and still having a genuine, honest conversation with them.
Yeah, and so I guess in addition to kind of all of that, what is, in your opinion, kind of a better age for someone to conceive with endo? Obviously, there's a lot more factors that go in than just deciding on what age.
Yes.
And then the other question was, if someone is in their mid-30s with endo, is there anything that they should consider to preserve their fertility, meeting with REI or freezing their eggs?
Absolutely. Excellent question, first of all. And I preface this by saying I am biased because I live in the world of endometriosis and infertility. So please take this with a grain of salt. And the second thing I always say is I chuckle and sort of rather laugh sarcastically at Mother Nature's sort of really inefficient plan for fertility for humans, because believe it or not, peak fertility in human beings occurs at age 22. Now, if I told this group of people what I was doing at 22, you probably would not invite me to another talk, because we are all children at 22 doing different things in our lives. And so the right answer to that question is, if means are present, because of course, in an ideal world, I would want everybody to have insurance on their fertility. We have insurance on our car. I have, knock on wood, yet to get into a car accident, but I still pay monthly for my car insurance. I'm not allowed to drive on the road unless I have car insurance on my car, right? I live in this house that has been fine, knock on wood again, but I pay insurance for that. So it is nothing else but insurance on your fertility. Egg freezing is a good idea for anybody, if they have the means to do that, financial means primarily to do that, especially in a state like Minnesota where it's not covered by insurance. Especially becomes more important for women with endometriosis, because we do know that there's an impact, or a significant impact, on fertility as well. The other thing is that when we look at egg freezing, the earlier, of course, is better, but we say any age is good. Ideally under 40 or 38 is the best time. But of course, the earlier the age at egg freezing, the more robust those gametes are. And that's just for Mother Nature's sort of inefficient plan. I still will call it an inefficient plan of fertility and aging.
Yes, Okay, so, and then kind of follow up with, the discussions for, treatments for infertility. We talked a little bit, getting into the Lupron, but is there anything, with endometriosis that you would do if someone has endometriosis? Would you do anything different for their infertility treatment if you were aware of that?
Yeah, great question. So if somebody has endometriosis compared to sort of the normal infertility person that we see, it again depends on whether or not they have adenomyosis. I think that's really important. So advanced imaging, I think, is really important and key, because the reason why I say that is adenomyosis is something that can be, it's a spectrum. So it could be really, really advanced and you could see it from 10 miles, or it could be very subtle and it could be a really subtle finding on advanced imaging like MRI. And I'll tell you, oftentimes our radiologists, even at Mayo, that don't do endometriosis, because we have specialized radiologists that just do endometriosis. But if sometimes the scan is not read by one of those 5 radiologists, they will miss adenomyosis, and we will catch them as GYNs, not trained radiologists that live in this world. So it's a very subtle finding. So the first thing is I sniff out adenomyosis, because it's really important, because it has a direct impact on implantation and fertility success. And the second thing is to see if they have bulky disease or not. Because if they're in pain and they do have bulky disease, I truly believe that excision of disease enhances their fertility and their response to fertility treatments.
Okay.
There's, of course, several kinds of protocols that we use that I don't want to get into the nitty.
Yeah.
I told you I would nerd out, so I'm gonna stay in my time. I'm gonna stay in my time frame. But of course, there's several different protocols. It's like IVF is like baking a cake, and sometimes we make a chocolate cake, and sometimes we make a sponge cake, and sometimes we make a upside down cake. And you get the gist of it.
Yep.
So there's slight tweaks to the protocol that can be done.
Yeah, no, that's very interesting. So to kind of follow up on different, so that was for treatments for infertility. Now, if we look at treatments for endo, obviously hormone suppression is one of those, but kind of how do we balance that with trying to conceive? And then we do have a question about, your thoughts on Orlissa use kind of prior to IVF, or when to discontinue.
Absolutely. So, that is one of the hardest things when we come to conversations about pain and fertility, and walking that tightrope and making sure that we're doing that balancing act. Now, the hard part about this is that if patients are in pain, we do know that medical suppression or suppression of ovulation and menstruation can help with pain. Of course, it doesn't eliminate the disease. We don't know if it halts progression of disease, but we do know that it impacts symptoms for patients, and it helps improve symptoms for patients. But on the other hand, these patients also want to get pregnant. So it's really hard to do that balancing act. So with fertility and pain together, what I do is I take imaging as my guide. As I explained to you, if there's advanced endometriosis, we do imaging and I see an endometrioma, I see a nodule, I see bulky disease, we most likely are going to move forward with surgery and excision of disease if the patient is willing to do so, because I know that post-excision, not only will the patient's pain improve, but also their chances of fertility could be heightened as well in that process. So in that scenario, with bulky disease, we would do excision of surgery, go right into trying on their own or fertility treatments. We can talk a little bit more about my bias, but for advanced disease, for example, my bias truly is to do advanced fertility treatments, because when you are faced with aggressive disease, you need aggressive measures to counter that. The data would show that about 20% of couples can get pregnant even after advanced disease excision surgery. But I am very, very skeptical about that data. I'll be very honest with you. The data comes from the centers that I've worked in Europe, and I still personally don't buy it because I don't see it in my patients. But that being said, it is not my decision to make. It is our decision to come together with a couple, right? And I would tell you, about 50% of patients in my practice want to try on their own, and that's cool. That's absolutely fine. But I think if you go and try on your own for like years on end, not a right decision. Still your decision, but I will be your advocate and still tell you it's a dumb decision, but I will support you in your decision and say, okay, fine, that's good for you. But please know that you're balancing that act and you're tipping the balance one way. Now, I think 3-6 months of trying on their own, A-okay. And then going on to oral medications and IUI, especially in a state where IVF is not covered, A-okay. But if we were living in Illinois or hopefully soon in Minnesota, if we're going to be covered, there is absolutely no question. I mean, why would I give you a subpar treatment? This would be the only area of medicine where I would give you a subpar treatment, right? So it's like if you equate this to cancer, and if the right treatment for cancer is chemotherapy, radiation, and surgery, it's like basically just offering the patient surgery, not giving them chemo and radiation. That is not done because that's not the ideal treatment for patients. So unless there are these financial implications lifted for our patients, we're not giving the best treatment to our patients. And because of these burdens that the health system has put on our patients, not because patients don't want to do the right thing for themselves. So that would be that. But if a patient comes in with no bulky disease, pain and infertility, then it's a conversation. Then it's a conversation of, do you want to try on your own? We could certainly try Clomid IUI. We could certainly do IVF. The advantage of doing IVF is you suppress, so you can stay on oral suppression and you can go through the cycle without ever having an ovulation and menstruation. But that sometimes is not the right answer for patients because it's not financially feasible or ethically, religious, moral implications. You know, that's why it's like not one size never fits all in endometriosis, and especially with endometriosis and fertility issues together. So it's a conversation. And I tell you, I have had patients that have gone to fertility treatments or even as much as IVF not because they were infertile or they couldn't try it. It's just because they could never get off of birth control. Because if they got off of birth control and ovulated and had a cycle, they were completely knocked out. They could not get out of bed at all because of the pain.
Well, it's good to know that there are options for those people with the pain. Because yes, that's definitely rough. So another question we have is, you know, how best to optimize fertility post-surgery, and are there any lifestyle changes that you recommend to those with endometriosis? Now, just briefly for myself, obviously, yes, I am probably not normal and getting pregnant right after. I had been doing an anti-inflammatory, quote unquote, diet for about 3 to 6 months before my surgery. So obviously there's other, you know, potential things, but what makes sense?
Absolutely. I think it's a great question. I will only talk about the stuff that we have data for and not the plethora of advice and information we have online. My primary philosophy in life, let's put it that way, is to not have a restrictive lifestyle because life is too short. Life is very hard. And especially it's harder if you're dealing with pain every day and fertility and infertility issues. I think that oftentimes our patients get sort of caught in this web of conversations that are misleading, in my opinion, that have absolutely no medical basis to them, but they are leading such restrictive lifestyles that my heart goes out to these patients because they're just trying to do their best. They would go, like I said, they'd go to the moon and back to have a baby and to be pain-free. The things that we do have evidence for is that when you do excision surgery, you do have a honeymoon period. Those cytokines do go down. The inflammation does go down in the pelvis. So to hit while the iron's hot, the first 6 months or so, this is expert opinion. There's no studies to prove how long that honeymoon period lasts. But anecdotally, it's about 6 months or so. I think that's capital time where if you were ever going to think about advanced fertility treatments, do them. If you're ever trying to get pregnant, do it. We have several patients that have partners that are across the globe and they want surgery and then they want to get pregnant a year later. And I'm like, no, we can do it, but I want you guys to be together after surgery so we can at least try to get to that goal of pregnancy, right? I joke with them and I say, we can't FedEx sperm, so we have to like be together around the same time right after surgery. So there is that peak in fertility right after surgery. As you mentioned, there is evidence for an anti-inflammatory diet for pain, but not for fertility. There is evidence for anti-inflammatory diet helping pain symptoms, But Amanda, I try to, and this is interesting, I digress here as well, but as a male OBGYN, I have to empathize that much more with my patients because I don't even know what a menstrual cramp feels like, let alone the issues with fertility and living with pain every single day. So I try my best to put myself in my patient's shoes. So believe it or not, I actually did go on an anti-inflammatory diet just to see what it felt like and how restrictive that was. And I tell you, it took me 72 hours of being exceedingly crabby and fighting with everybody and getting off of it. 72 hours that I chickened out completely. This is a real life experiment. It is exceedingly restrictive, as you know. But for people that it helps, you will start noticing that change. You'll start feeling better. You'll start getting less pain. And I feel like people will feel that difference. So if it works for you, more power to you, do it. But if it doesn't, what is most important here that I tell people is don't feel like you are a failure because you're not doing all these restrictive things for your lifestyle, because there is absolutely no evidence for any of that. And the last thing I want you to feel is feel like a failure or have that self-worth issues or self-helplessness and things like that. You're going through so much as is. I can tell you and I can speak for men for sure, but like if anyone of us were going through any of that, I tell you, it took me 72 hours to quit that diet, right? And you probably did a good whole few months of it, right? And I'm always in awe of the lengths people will go to help themselves, really. And this is what, again, talking about passion of this area, this is what keeps me engaged and passionate, because patients are what keep us engaged, and there's so much enthusiasm and passion from patients. But I'm not a huge advocate of restrictive lifestyles, or sure, you can do acupuncture, sure, you can do Reiki, sure, you can whatever, you can do sit-ups and whatever. If you search it, there is something out there for different types of things to do. But honestly, there's no data. What I tell my patients is, you can help yourself by doing fertility treatments, not doing all these other restrictive things. But sometimes patients don't want to do that, and that's okay. They say, I will do X, Y, and Z, but I would never do fertility treatments. And that's A-okay. But one thing I promise my patients is a transparency and a lack of filter. I just want to make sure that I can tell them what I think. And am I 100% right all the times? No, because science doesn't know all the true answers. So how am I supposed to know all the true answers? But at least when I live, breathe this every single day, you learn, you change your practice with what you see with your patients, and you just go on what you see daily with your patients, sort of a thing.
Okay, very good. No, thank you for that. I think, yes, focusing on, what has research shown is really good, because it is definitely a rabbit hole that you can end up on. Let's see here. So we can get to more of the questions in a few minutes. I just wanted to first kind of touch on the research that you're doing with Mayo, and then if anyone else has additional questions in chat, I know I see several of them, so we will get back.
Yeah, I do too. Yeah, absolutely. Well, I can talk really briefly about my research, and I feel like we probably should answer most of these questions. People have really good questions, but like, okay. I don't want to stay too much on my pedestal, but I just want people to know that like the reason why I'm in this field is because I also like a lot of basic science research, and I did a master's in clinical research, and we're very heavily engaged with basic sciences research. And to me, the fascinating part of this disease is that we still do not know what drives the disease. And why is it that 10–15% of the population will have the disease and the rest don't? And there's several proposed hypotheses. I'm sure people know about, the retrograde menstruation and, the spread through blood and spread to lymph nodes and things like that. But the key thing that we're emphasizing in our research group is really looking at the molecular signature. What happens on a cellular level in women with endometriosis compared to those that don't? Why do certain women have pain when they have endometriosis, majority of them, but certain women have no pain at all and can walk around with advanced disease? Why do certain women have that garden variety endometriosis that respects tissue planes and just stays on the surface of organs, whereas other patients have disease almost acting like cancer when it invades into the bowel, it invades into the nerves, and it invades into the bladder and into the uterus. And what we are learning more and more is that it is basically not necessarily the disease, but our immune response to the disease and the lack thereof that causes advancement of disease. So, for example, we're studying a group of patients that have bowel disease, that have deeply invasive disease into the rectosigmoid. And when we take the molecular signature from those women, molecular signature meaning what is happening to the different immune mediators, what is the conversation happening between your immune system and the disease, we can test that in the lab. That is very similar to people with colorectal cancer. Endometriosis is not thankfully cancer, but the implications of it are anything but benign because it seeps into every facet of your existence and your being. And it is, as a scientist, it's so fascinating to see that if I took 2 slides and 2 signatures, one patient with cancer, one patient with bowel endometriosis, I couldn't tell them apart. How fascinating and crazy is that? I mean, this is a disease that is such an enigma. And the reason why we're trying to do that is because the medical management strategies for disease that we have right now are not the best at all. A lot of women have side effects from birth control or hormone suppression. A lot of women want to get pregnant and can't be on those medications when they're trying to get pregnant. A lot of women have medical contraindications to those medications like blood clots and family history of blood clots and things like that. So what we are trying to see is, can we find out some medications that would nip the disease in the bud on a cellular level before it even progresses to something that we can physically see with the human eye? So that's some of the area of research that we're doing with endometriosis. Of course, there's a lot of other research that we do for education and training purposes and for training other surgeons how to do the correct surgery and how to approach these very, very difficult, complex cases in a multidisciplinary manner, because this is truly a team sport. You can't play football on your own. That would be a boring game. You need a whole team of people helping you and really doing what they know best to cater to the patient.
Yes, absolutely. No, that's very interesting. I am just going to pull up the questions here and figure out which ones we haven't answered already. I think there's one at 7:34 that we had skipped, which was
7:34. Do you have any favorite supplements, that one?
Yes, that
Okay,
one.
let me read the question out if that's okay for the recording. So the question is, do you have any favorite supplements or protocols for embryo transfers? I've heard downregulation lasts approximately 6 months, but if endo symptoms have returned within 3 months, is it possible that you are no longer downregulated? I've had 2 failed euploid transfers, stage 4 endometriosis, rheumatoid arthritis, and I've had excision surgery as well as downregulated with Orlissa one time and Mefremdi the next time. Excellent, excellent question. Favorite protocols, so know that the best guidelines that I can refer you guys to, because the one thing I'm going to say here, and I really truly mean this, endometriosis patients are some of the most educated and fascinating people that I have met in my medical career. You guys are amazing with the amount of knowledge that you bring to each appointment and the amount of, like I said, passion and enthusiasm that you bring. So I just wanted to make sure I say that, because this is a question that even an advanced fellow can ask, right? I mean, this is, I hope you're in medicine, or if you're not in medicine, kudos to you, because this is an amazing question. And so really, for protocols, the best guidelines that I can give you are ESHRE guidelines, ESHRE. It's an acronym, European Society for Human Reproduction and Embryology. It's actually a European society, believe it or not. It's not a North American society. And ESHRE has some amazing guidelines. I personally worked on those as well with ESHRE to update those, that really talk about best protocols for embryo transfers and how do we deal with advanced fertility treatment in the setting of advanced endometriosis. The best data that we have is to go on suppression with either Lupron or Mefremdi or Orlissa. The next best thing we would need to do is to make sure that they are tested embryos, because 8 out of 10 times when an embryo transfer doesn't work, it's it's because the embryo was abnormal or the chromosomes on the embryo was abnormal. So making sure that the embryos are genetically tested, and then doing all those, putting your best foot forward and saying, my disease is excised, I don't have bulky disease on imaging anymore, I am adequately suppressed prior to each embryo transfer, and my embryos have been tested each time. So I've put it in a normal, chromosomally normal embryo back into the uterus. And if we do that a good 3 times, the data would really show that we ought to change something in the equation, primarily the uterus or the incubation part, which is a gestational carrier primarily. Now, like I said, sometimes that will never be a choice for couples. And in that case scenario, we just have to go through their embryos one at a time. I would still not do double embryo transfer because 2 does not mean you're going to get pregnant. 2 only increases your chances of twin gestation, which further complicates things in pregnancy, but also burns through your precious resource that much faster. So if you have tested embryos and gestational carrier is a no-go zone, then I would really go and continue to do embryo transfer after embryo transfer, which I know sounds so frustrating. It does, and it is frustrating as well because it's a resource, it's a time suck, it's a commitment. But if you truly look at the data and follow the rules of mathematics, you ought to deviate towards the mean, which means the mean is a positive pregnancy test, yes. So there is literature from, say, Boston IVF, where it's covered by state insurance, that this is a crazy number, but it just proves the theory. If women, irrespective of age, irrespective of diagnosis of infertility, undergo up to 6 embryo transfers, 98+% would walk away with a positive pregnancy test. So it's the number of times you continue to hit the bullseye, granted, knowing hitting the bullseye or even attempting to hit the bullseye is 3 months or 4 months of your time. It's thousands of dollars. It's riding that emotional roller coaster all over again, right? I mean, it's easy. I can say this in one sentence. Yeah, I continue to do embryo transfers, but doing it and actually going through that process is going to the moon and back or hell and back, right? And that's what I truly try to empathize with my patients and say, what is your breaking point? What is your limit? Because I'm willing to play this game till you are. We're in this together.
Yes, thank you. I can read out the next one that we have here. So we'll just go through the chat kind of in order that they've been on. So what are some things we can be asking or bring up to our local infertility doctors? This person had a successful surgery with Dr. Palmer a few years ago, but lives quite far away. And so they don't have an endo specialist, I'm assuming, in the area.
Mm-hmm. Great question. I would say continue to advocate for yourself. And I don't mean to be critical of my colleagues in the fertility world, but my colleagues in the fertility world do one thing really well, and that's fertility treatments, whether it's Clomid IUI, whether it's IVF, but tend not to know too much about endometriosis. And that is why, like I mentioned, I did 5 extra years because I wanted to be that think tank for both areas and bridge the 2 worlds together. So continue to advocate for yourself. Continue to make sure that you do not have recurrent disease or you don't have adenomyosis. It's really important to understand that. Oftentimes I get referrals from fertility providers where their patient has endometriomas and they have pain and they have obvious disease, but they say, oh no, we'll put you on Lupron and we'll just do embryo transfer after embryo transfer and see if it works. Because, oh, by the way, pregnancy will be helpful for your endometriosis. If I could get $1 for each time I heard that, I would be sipping pina coladas on my private yacht right now, right? And so it's really, really important to advocate for yourself and to really make sure that your fertility provider is not just thinking IVF, 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 even though I've been talking a lot about IVF as well, but there's a role for IVF in advanced disease. I don't think IVF is a one-size-fits-all either. So it's really important to rule out adenomyosis, to make sure you're having some embryos that are euploid embryos or good quality embryos, and really making sure that you don't have any recurrent or residual disease. With most patients, I would say, they would have to tap into 2 sources because they have their endo doctor and then their fertility doctor. when you're meeting your fertility doctor, make sure you've met your endo doctor and they've cleared you and they've said, yeah, there's no active disease, we don't see anything, ovaries look good and quiet, you're ready to move on to fertility treatment, sort of a thing. So those are the some things that I would consider keeping in mind when you're navigating these two worlds.
Very good. And then the next one is, they were asking, is any of the advanced imaging that you went over, is Mayo the only location in Minnesota you can get that, or do you know of any other location?
Yeah, great question. Unfortunately, Mayo Rochester right now is, because we are even trying to implement this in our Mayo Clinic health system, which is across Wisconsin and Iowa, and we're getting a lot of difficulty because we just don't have the quality of MRI machines in our community, like the 3.0 Tesla. The ultrasound is not only just Rochester specific, it is one radiologist in Rochester specific. That's how specific it is. Only one person can do that specialized ultrasound. That's a 90-minute ultrasound with a bowel prep and everything else. Even I can't do those ultrasounds. So it's really, and again, this is why I keep going back to saying we need more people in the workforce that can handle these things. And I'm excited. It's premature, but there's more coming in the pipeline where there's going to be more expansion even within our practice, and we're really excited about what's more to come. But unfortunately, right now, it is only in Rochester, and there's a long wait time. Like if I see a patient, I can't get them in for that MRI for at least 4 weeks or 6 weeks. It's depending on the calendar.
Gotcha. Okay. And then someone was asking for clarification on hormone suppression with Orlissa in this case.
Yeah, this is 741. You mentioned Lupron, but any thoughts on Orlissa? Great question. We are currently enrolled in a trial for that. We're currently enrolling patients. It's a multi-center trial through Yale, Mayo, University of Colorado, and Cleveland Clinic primarily, but there's several other sites too. There's about 12 sites that is looking at this exact same question. Is Orlissa and Lupron interchangeable? Because why give a shot to a patient and get a lot of those side effects, even though Orlissa has similar side effects as Lupron, but not as bad as Lupron. I don't like Lupron for endometriosis treatments because Lupron has a lot of issues, but I like it in the setting of preparing patients for embryo transfers. But to answer your question, it's in the pipeline. We'll get some more data and we'll get some answers by middle of next year, I'm hoping, because we're about ready to close that trial. But we will have some meaningful answers very soon. Right now, when I look at their mechanism of action and when I look at the pharmacokinetic data, which means like what it does to your body and what the levels of drugs do to your body, and when I compare Orlissa and Lupron, I think they're fairly interchangeable. So I leave that decision up to the patient. I say Lupron is our gold standard, but both are, this is like driving a car. A Camry can get me to work, a Ferrari can get me to work. My goal is to get to work, not what car I'm driving at this point, sort of a thing. So I think either or, and this is where, individualized conversations with patients and making sure they have buy-in. What I've learned in medicine at a very early age, there's a science to medicine, which is easy because if you read and if you're up to date, the science is easy. But there's an art to medicine, to practicing medicine. And the art of practicing medicine is something that we learn on a daily basis. I learn on a daily basis. And that art is whatever decision you make with a patient, your patient has to have buy-in and your patient has to be absolutely on board with what decision is made together, not what you've dictated to the patient based on the literature, right? And so I think that medicine is magical when you apply the science and the art of medicine together.
Wonderful. And then if we jump down, there's just a clarification on that at 753 to clarify. So staying on hormone suppression throughout the IVF cycle, is that what you would recommend generally speaking?
To clarify, it sounds that if you're staying on hormone suppression, or Orlissa in my case, throughout the IVF cycle, what would you recommend? Okay, so let's talk about this. So the beauty of sort of like, I think this probably came out when I explained to you an example of a patient that I had that could never get off of birth control because each time she would get off, she could not get out of bed with ovulation and menstruation and was literally in the emergency department every single time. In those cases, you stay on suppression right till when you start the stimulation. When you start the stimulation, we actually don't use Orlissa. You can use a specific protocol that has small doses of Lupron or another injectable form of antagonist, which is like Orlissa, called ganirelix or cetrotide. Now we are gathering more data of whether or not we can use Orlissa throughout that cycle, but you're using sort of a different variation of suppression during an IVF cycle. So yes, you do stay on suppression technically, whether you're on ganirelix, cetrotide, or Lupron during an IVF cycle. But know that when you get eggs, that lining that is built during an IVF cycle still has to be shed. So there is a period that will happen after the IVF cycle. That's something to keep in mind and something to think about. But it at least it's better than people that are doing Clomid IUI every month, having a menstrual cycle and ovulation. That for some people can be very, very sort of traumatic and a lot of very much pain inducing, where they can't do it. So they say, well, I'm in so much pain, I can't even have sex, and immaculate conception happened 2,000 years ago. So it's not gonna sort of a thing. So that's sort of a, I mean, these are practical, real deal scenarios. Like, how can you have sex when you're in pain? Like, how can you try to, achieve a pregnancy every month when you can't get out of bed when you're ovulating and menstruating? You're in so much pain. So that sort of a thing is where when we talk about advanced fertility treatment, at least keeps you suppressed throughout.
Okay. No,
and that's not a conversation about whether or not this is disease progressing or not. This is merely symptoms, symptoms.
Okay. No, it's good to know that you can minimize the symptoms and still do the advanced fertility treatments, at least for the most part. And then I just want to address the fact that we've had a couple of comments about Minnesota and the potential for fertility insurance coverage.
Yes. Please write to your representatives. Every single one of you on this meeting, I would love for you to call your representatives, to write to them. There's a bill in the House. The House got a lot of support. Last year, we were this close to passing it. We are so excited. We had an advocacy day on the 14th of, on Valentine's Day, advocacy day on Capitol Hill. Please get involved. Please vote for the people that you feel are going to stand for your reproductive rights. And we're all in this together, and we all have to fight to get this approved. And we're so close. And I really, 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 in my heart of hearts, think that this is going to happen. It is going to happen.
It would be amazing. I know state employees were able to get fertility coverage 2 years ago.
So please, if you're listening on this call, please get to work. It's just an email. It's just a phone call. I do it every day. I do it in my crazy schedule, in between cases, in between OR days. I'm calling. I'm literally leaving. I mean, my name is Mud probably, because I'm like, this is me again. Like, so every day.
Yes, absolutely. All right. I think we will jump down 757. So speaking of the spread of endometriosis, she's read about, it's spreading as far as the sinuses, nasal passages. Is this a proven fact or assumption? How can endo get past the pelvic or abdominal cavity? I mean, we don't know, but any hypothesis?
So I'll give you examples, but I give these examples with caution, okay? Because when you have such a chronic, long-lasting disease, as more and more diseases occur in our body, people tend to say everything is endometriosis, and we as doctors do that, which is so wrong. This is why I tell people that if you don't have endometriosis, and we prove that you don't have endometriosis, you have pelvic pain, but you don't have proven endometriosis, let's get that endo label off your chart. Because I joke with my patients and I can say, you could be possessed by the devil and growing horns. The ER will still say, oh no, this is endometriosis. This is like a horn growing on your head, but this is endo. So it's really important to not get misdiagnosed, but also to understand that endometriosis, when you see this disease day in, day out, you can see multiple variations of it. And I'll give you some really unique examples that I have personally seen, but that doesn't mean that every person with endometriosis will have that. So I plead with you to be cautious that don't miss other important signs in your body and say this is endometriosis. And I'll give you an example of why that happens too. So I have seen endometriosis in the brain with monthly seizures. I have seen a monthly red eye in the sclera, that's endometriosis. I've seen monthly nosebleeds with endometriosis in the nasal cavity. I commonly see people with lung collapses. Actually, I just have 2 surgical cases this week with endometriosis in the chest. We see endometriosis, oh, by the way, in men that have been on Lupron treatment for prostate cancer. We see endometriosis in neonates. My youngest patient has been 14 hours old, okay? So it is really important to know that endometriosis can come in different flavors and forms, but I also have had a patient that had monthly seizures and was absolutely convinced that there was endometriosis in her brain. She actually did not have endometriosis even in the pelvis and had a brain tumor that she sat on for months because she had convinced herself, because she had read about it online and had convinced herself that this is endometriosis. So I caution and I plead with people to say, yes, these zebras of endometriosis exist, but when you hear steps or animal-sized horses rather than zebras, right? And so it's really important to understand that common things are common, but of course, uncommon things can happen. But I caution you not to miss other common things thinking it's endometriosis.
Thank you. Yes. And then there is a question after that, 802. I'm gonna let you read that one.
Can endo create a higher than average for age rate of aneuploid embryos? Excellent question. See, I'm fascinated by these questions. That's amazing. With unexcised advanced disease, how is the success rate of IVF with highly graded embryos impacted? I have 1+ endometrioma and have not had excision surgery. My son is 11 months old, yay, from that first FET and from frozen embryo transfers, and hoping for success sibling in the future. Wonderful. First of all, congratulations. That's awesome. Secondly, you ask an excellent question. So we still don't have good enough data to show that presence of an endometrioma is whether that's going to impact your fertility outcome or not. In your particular case scenario, I actually let pain be my guide. If you are in pain and if you are in discomfort, we ought to look at excision of disease prior to doing the embryo transfer. But if you don't have any pain issues, you have had success in the past, I would possibly talk to you about moving forward with a frozen embryo transfer after appropriate suppression, because we do see success there. So if you look at the ESHRA guidelines, every endometrioma does not need to be excised. Actually, endometriomas less than 1 centimeter, if you excise them, you're looking for a needle in a haystack and you're causing more ovarian damage in the act of removing that endometrioma and further reducing your ovarian reserve. So there are patients, this is why one size doesn't fit all. And I hope I'm not confusing the audience, but there are patients where they have an endometrioma, they are in their 4th decade, they have borderline ovarian reserve, and I know if I do a surgery on that endometrioma, I will tip them to a point where even IVF will not gather or harness any eggs from them. So those are patients that we actually do IVF first before going to surgery. And I think there was a question of what comes first, IVF or surgery. There's no standardization of that. It has to be case by case dependent. And the things that guide that is your age, your previous success or your previous fertility history, the size of the endometrioma, the number of endometriomas, and whether or not you have a good enough ovarian reserve around the endometrioma so we can stim you and get eggs around the endometrioma, but leave the oma as is in place. So I hope that answered some of the questions, but in your particular case scenario, if you're asymptomatic, I think going on to a frozen embryo transfer is A-okay, and there's no data to show that removal of that oma versus keeping that oma will have any difference in the outcomes, especially if you've had success in the past.
Next one is, when endo spreads to the sides of the abdomen, is it sometimes necessary to remove the spleen? And is there a way to preserve the spleen if it has been impacted by endo?
Yeah, great question. So if you have proven endometriosis in the spleen, then there's no other ways around it. There's some innovative therapies. So I see a lot of endometriosis in the liver. I've never seen it in the spleen. But first, I would I would further question why we think there's endometriosis in the spleen. How do we know if there's endometriosis in the spleen? What kind of imaging has been done? Has there been any biopsy of that? I commonly see endometriosis in the liver, and yes, the anecdotal, or it's like the archaic way or the classic way or the gold standard way is excision, because that's not going to miraculously go away. Medical management is not going to completely ablate that. But we are using innovative therapies. We're using interventional radiology and cryoablation, so we can freeze these areas. We can ablate them with alcohol and sort of ablate, meaning burn that area completely, and completely get rid of that little deposit in a deep organ that is otherwise vital for function, and that otherwise removal of which can cause a lot of dysfunction. Now, the liver, of course, we can do segment resections, but that's still high-risk surgery. And sometimes we choose to target those lesions with interventional radiology. I have personally not seen spleen endometriosis or read about it, but I would first sort of really understand the diagnosis and really make sure that it truly is endometriosis in the spleen. And then, honestly, like in the spleen, you could think about interventional radiology procedures, but most people will think about a splenectomy at that point if it's truly causing you pain and discomfort and issues.
And the next one is about, can endo cause prolactinoma?
The answer to that is no.
Okay. And then just a little bit of a question about kind of the Mayo reproductive endocrinology and infertility team working together for infertility treatments.
So I primarily consider myself a reproductive surgeon or an endometriosis expert, but I chair the division of reproductive endocrine and infertility at Mayo. So I'm board certified in reproductive endocrinology and fertility, as well as minimally invasive surgery. So the way we work with patients with infertility and endometriosis is they typically start with me, and we talk about surgery, no surgery, treatment protocols, what we need. We have that initial consult. If you need surgery, I do the surgery, I do the post-op, and then we go on to our fertility team. Now, understand that I'm an N of one. I'm one person with 24 hours in a day and 5-day work week. So I can only be in certain places. So I do some fertility, which is on Tuesdays, but the rest of the time I'm doing surgeries and trying to get the caseload of patients through surgery and excision surgeries. So when it comes to post-operative fertility care, even though I am calling all the or orchestrating the treatment modalities, you may or may not see me particularly in clinic because I may be in the OR. So you may be seeing the team, but what we do is we have a group practice, meaning that in my team, which is a reproductive surgery team, not the bread and butter fertility team, but the reproductive surgery team, we have myself, 2 other MDs, a nurse practitioner, and 3 nurses that only work with patients with endometriosis and fertility issues, or surgical or fibroids and infertility issues. And I'm still making decisions behind the scenes on your fertility protocol, how you're responding, what do we need to do with the medications during the fertility cycle. But because I'm physically either in the OR or seeing new consults for surgery, I may or may not be able to see people in the fertility clinic. I still do fertility clinic, but it's for 1 day a week rather than 5 days a week. So it's just important to understand that when it comes to fertility treatments and the flow of things, your time is more important than mine. So I don't want you to be waiting 2 months for my next appointment just to see me, to tell you something that I can decide behind the scenes and have my team discuss with you. That's sort of our approach typically for patients with endometriosis and fertility issues.
Thank you. Okay, I think we'll do a couple more and then we'll be wrapping up. So do you know of any kind of good resources for up-to-date research?
Yeah. ESHRE guidelines. Okay. I've referred to that earlier, but ESHRE, I think they're written at a fairly non-medical level. I have no doubt that at least people on this group would understand this, because I tell you, I truly mean this. I know I'm repeating myself, but I'm in awe of how much you guys already know about the disease and how much already you know about the medicine of this. So I have no doubt that ESHRE guidelines would be very, very helpful for people. And then I think PubMed, search people that you trust and you know that do quality research and provide endometriosis care. I myself, including a lot of my other colleagues, have published a lot on this, and the biggest thing that I give to my patients is a review article that I wrote about endometriosis and fertility implications. Like, how does endometriosis impact fertility in general? It was in abdominal radiology. And so a lot of patients really find that helpful. And I'm not saying just read me, read everybody's work if you want to. I think it's important. But what I caution, as much as I respect the online communities and the grassroots efforts that are being made, I really caution people to take everything with a grain of salt, because different people's experiences are different and different people are different, right? So Amanda, let's pick on you, right? So not every person that will have surgery and goes on an anti-inflammatory diet will get pregnant on their own. And that's the truth of the matter. And so it's really important to understand that even though there is this sisterhood, which is so important, because we have to lean on each other in these circumstances, and we have to learn from each other in these circumstances. You are your unique individual person, and you ought not to be compared to other people. And I think that's really important as well.
Yeah, and my background is in research, so not in the medical field at all. So I'm just going to say the thing about research is it's research. It's always new. It's always developing. You're always proving or disproving something. So things shift
Absolutely.
very quickly.
I believe Einstein said, if we knew the answer, we would not call it research. So it's just continuing that pledge to continuing to find more answers.
Absolutely. All righty. Let's see here. When you are assessing pain with endometriosis and determining whether excision is recommended, does the timing of the pain factor in, if it's during menstruation or not?
Excellent question. Yes and no. I think that people that truly have cyclic pain, just extreme pain during menstrual cycles, pain during ovulation, there are higher chances that we would find disease and excision, you would get better. For people that have had that and now it's gone to everyday pain, that gets a little tricky, because everyday pain could certainly be endometriosis, and excision of that can certainly help with pain. But it is also, remember, pain is nothing else but traffic in nerve fibers. So when nerve fibers fire, we experience pain. And when nerve fibers fire 24/7, that's because they've usually been insulted to the point where the pulse generator continues to fire. And sometimes it is difficult, especially if you're in daily pain and you don't have obvious bulky disease. You may still have minimal stage endometriosis, and excision of that may still help a little bit, but mostly people that don't have obvious disease on MRI and have daily pain, they truly still are in pain, but that likelihood of a response from that surgery is a little bit lower. But we still have to, it's a hindsight always. We almost have to work through those motions and prove to ourselves that, okay, look, now we've excised all endo, we're on suppression, but we're still in pain every day. That doesn't mean that this is in your head. You are in pain. You're not making this up, but let's at least try to shift this focus and saying, yes, my pain started from endometriosis, and now it's an aftermath of endometriosis. Even though my disease is gone and I'm keeping microscopic disease suppressed, I am still in pain. Let's do something about that. And I tell you, another surgery is not going to help in that scenario.
Gotcha. Okay, we are almost out of time, so I'm just going to ask the last one, if endometriosis is linked with the MTHFR or the COMT mutation.
Yeah, great question. There's still more research in the pipeline for that. The MTHFR and the COMT mutations are now becoming more and more common because we're seeing them and we're testing for them more. There isn't any good body of literature that I can quote to you to say, yes, there's a true link or a correlation or an association. It's basically, the thing that I talk about is like the biggest risk factor for cancer is life. You have to live to get cancer, right? So you can really associate anything with anything, but it's typically garbage in, garbage out. And right now it's sort of at that phase where we don't see any link, but that could truly be different if we had this conversation a year or 5 years or 10 years from now. But as of right now, there isn't any strong body of literature evidence that supports that.
Okay. Thank you. I know we are out of time now. I know there's a couple more questions, but we do still have more doctors, 2 more sessions for the rest of the month. So we will add those questions for them because we're meeting with 2 more Mayo doctors next Thursday. So we will write those down. Thank you so much for your time.
Of course, it is a pleasure and a privilege to speak to you guys. I did put that 507-284-9792 number in the chat as well if somebody wants to seek any opinions or anything at Mayo. I hope this has been helpful. I want to leave you guys with a positive note in saying that you are not alone. None of this is your fault. Oftentimes, patients come to me and say, oh my God, I smoked during college, or I did this and now I'm paying for it. None of this is your fault. I truly mean that when I tell you this. This is something that happens to the best of us. Endometriosis is truly a disease that can happen. Please know that this is not in your head at all. If you are in pain, you are in pain, and you ought to be validated for that. And please know that, we empathize, and the best I can do is to be very honest and transparent with my patients. But please make sure that you are heard, that you are an advocate for yourself and an advocate for your neighbors, your girlfriends, your sisters, your cousins. Endometriosis truly is a subspecialized disease. And just like I would not send a family member that has GYN cancer to a general OB/GYN, I would not send a family member that has endometriosis to somebody that doesn't specialize in endometriosis. And I leave you with that. Best of luck in your endeavors, and please, I hope that this was helpful, but please be a part of this grassroots movement of awareness, and especially for fertility coverage for us in the state of Minnesota. We're all relying on you guys. So thank you so much for doing that.
Yeah, wonderful. All right. Well, we will see you guys at the next one. Thank you so much for your time.
Thank you guys so much. I really appreciate this. Bye-bye.
Bye-bye.